And for the last group of this presentation, I'm going to call up Keisha Gibson and Laura Mariani. Keisha is Assistant Professor of Medicine and Pediatrics Chief. She is primarily interested in research in lupus nephritis and other glomerular diseases. She's specifically interested in ethnic socio-demographic disparities. Laura Mariani is a nephrologist and clinical researcher at the University of Michigan, and she's a primary clinical and research interest in observational studies and glomerular research. Thank you.
Okay, good afternoon. Is it afternoon yet? Almost there, almost lunchtime. Don't rush it. Well, it is definitely a pleasure to be here today. You've just heard a presentation from a project that, two projects that are well on their way. It's my pleasure to introduce you to a new project that has been recently approved by the KHI, and Laura Mariani and I have the distinct honor of co-leading. So, very familiar to many of you in this audience, FSGS is a rare and very heterogeneous disease. The disease itself is almost as diverse as the populations that are affected by it. Children, adults, hits almost every ethnic group, probably with definitely some disparities that we see in underrepresented minorities. And we've seen a pause in our progress in the treatment of this disease. As many of you know, this disease is marked clinically by slow progression, and so dependence on traditional endpoints such as change in GFR or progression to end-stage kidney disease often precludes us from seeing the successful conclusion of clinical trials that are dependent on those endpoints. And so there's really an urgent need for us to identify more intermediate surrogate endpoints that would be good candidates for us to consider. The charge of our group is to interrogate available FSGS data sets, look at existing literature, and try to seek out these potential candidate surrogate markers. And center and key to all of this, as we've heard distinctly over the last day or so, is keeping patient-centered outcomes at the forefront of this. So because this disease is so diverse and very complicated, we wanted to be very thoughtful of making sure our work group was equally diverse. And so you will see that we have plans to invite members of pediatric nephrology, adult nephrology. We have individuals that span the gamut of industry, government agencies, the FDA, and definitely our patient care partners such as NKI. We want to be thoughtful about the next generation of learners that will be helping us to combat this disease, and so we do have plans to invite fellows as well. So our project plan is divided at this point into four entities. Phase one, we really want to spend time understanding the regulatory overview as it stands now. This disease is extremely diverse. It's going to be important for us to be thoughtful about defining FSGS subgroups before we get started of interest. I think you've heard from other speakers before that we do have a tendency to put everybody in the same basket, and we may be dealing with separate diseases. We want to be thoughtful about that. Before we zero in on specific candidate endpoints, we want to make sure that we bring patients to the table to help us decide what candidates are important, what are the symptoms that are important. As a pediatric nephrologist, I rejoice when I see a urine protein to creatinine ratio of 0.2. But if I'm dealing with a family that has steroid-dependent nephrotic syndrome, they may not care if we're stuck on steroids or if my child is taking 23 pills twice a day. So we want to be thoughtful about making sure that patients have a voice at the table to make sure that we are investigating all potential surrogate endpoints. The second phase of this project will be for us to identify gaps that could be filled with additional analyses, and we want to develop an analysis plan around that with planned data analysis. We're hoping that this will all lead to a manuscript that will help guide our conversations with the FDA and other regulatory bodies, and then ultimately lead to helping our community as a whole develop novel trial designs. So our timeline that we've established for this is fairly ambitious, but we are very optimistic. So we have just gotten started. We have with our co-chair selection and our project plan development. Invitations are going out to these working group members, so if you saw your name up there and you're wondering, what's going on, don't worry, your invitation is in the mail. We are planning our introductory call within the next month or so, and we'll get started with the literature review. Hopefully mid-2018, we'll be well into our literature review, and we'll start having potential face-to-face meetings and be well on our way with our analysis plan. And our hope is that by mid to late 2019, that we will have a product that we'll be able to present to everybody. And so we are very thankful to be here. Today was largely an introduction to this new project that is launching. We are eager to hear feedback. We're eager to hear about challenges and solutions to those challenges and triumphs that other project members have faced. So thank you for your time.
That's a great way to invite people to help you with your project, Keisha. Really clever. So please feel free to come to the microphone. I'll start with a question. I'll take the chair's prerogative, and I'm going to ask Patrick and Elise a question. Patrick, you're involved in IGN and FSGS. You seem to be involved in a lot of projects. So I'm kind of curious what advice you have for the rest of your panel members about conducting this project in this very difficult space. And then Elisa specifically, I want to ask you, what's your recommendation not only for this panel, but for the investigators who are thinking about studies in some challenging areas, things like surrogate endpoints? How should they think about approaching you and the FDA specifically? Patrick? See if it's,
so my first advice, I don't know if you can hear me. That would help, wouldn't it? Still not?
No.
There we go. So my first advice is to work with Elisa. It's been incredibly informative. Really enjoyed doing it, Elisa. Thank you. Learned a lot. Thank you. I think that what I've learned from doing this is so for each of these projects, there are a great number of questions that can be asked, and one of the challenges is we all start with a long list of to-do things and goals, and it's important to break it down into chewable bite sizes and achievable goals in a timeline. I think that focusing on specific achievable goals is the way to go, even if that means doing this iteratively so that the entire list can be addressed eventually. That's my major recommendation.
So let's see, if I keep talking, it'll, oh, I like that. So I think my question was focused on ways to interact with us as a regulator. Is that sort of it? So I'm going to tell you the old approach, and this was sort of what we were up against, I think, historically in our division. So obviously in the renal space, it is essentially often about surrogate endpoints because the outcomes we care about are so far off, and that's especially true if you're talking about rare, uncommon diseases. And every disease you heard about this morning classifies as rare or uncommon. So historically how it went is sponsors would come in, they proposed something, and it was very hard for us to, within these short meetings, to understand the data and whether they were really strong enough to support the use of these proposed endpoints, these surrogates, as a basis for full approval or accelerated approval. What has now changed is that we have KHI, and we have other groups, and we have these opportunities to interact where we as regulators, and there's other regulators sitting in the audience, can tell you about how we think about the evidentiary standards, probably not the best term, but the type of data that you'd want to see to support a surrogate endpoint. And then we can work with the community who has the expertise, who knows what data are out there, who knows the limitations of the endpoints and the limitations of the data around them, so that we can really forge a path forward. So in terms of how to interact, I mean, this is it. This is where you can interact. And I think that we all try to sit on these groups, both on the drug side, and I know CDRH and CBER also sits on these work groups because we want to have the dialogue with you all. We want you to succeed, but it really takes your expertise and knowledge of the disease area.
Eliza, do you have some sense how soon investigators should come to talk to your division? Sometimes people feel like if they come, they got the one shot at talking to you and they're not sure when to time that because they want to be sensitive to your workload, but when's a good time to come and talk to you? What's the right stage? How do they know?
So, and I'm going to phrase it two ways because there's part of my job is as you know, I review commercial drug development programs, and we as a division are happy to essentially meet with sponsors whenever they, you know, not whenever, but we try to be very open to having meetings, and so they'll come in for advice, and we are very happy to have follow-up meetings to discuss the advice that we have given. Often in rare disease spaces, it's an iterative approach. There's feedback and further discussion. In terms of interactions with you all in the community and academics and other people who are trying to address these larger issues. Again, I think KHI is a wonderful opportunity. I also get emails from a lot of you, and I think that that is great as well. Both emails where I very much appreciate it. Kevin does this for me, you know, sends articles that I should read and things that I should know about. There's a lot of amazing, wonderful things that are being done, and it's very helpful to be alerted to them and also helpful to understand when there are issues that we as regulators can impact to start engaging in a dialogue about them.
So I'd love to pick up on your comments and your question, and I'm going to prepare the industry members that are in the room who've been a part of these projects in particular. So one of the things I find in the position that I'm in is that we're often comparing nephrology to other diseases. And we said, only if we were oncology or only if we were cardiology, it would be better. And yet, at this meeting in particular, a number of you have already come up to me and said, boy, this is an exciting time, and there's so many things that are going on, and boy, this was a good use of my time to be here. So thank you for coming up and making sure that the work was worth it. But I want to point to those of you that are in the room who aren't on the panel that are from industry to get a sense from all of you whether serving on these work groups is a good use of your time, whether it is driving towards, and how do we transfer that to other sponsors who are new, who are coming here, who maybe haven't, and really the advantage that as a community you have is to submit new ideas, to help us continue the momentum after that 12 months, and each of these groups are gone, to pick up the next idea. So anyone in industry who wants to respond from your experience? I didn't happen to stand next to you.
Well, but I took the hint. So I'm Anna Maria Kaus. I'm Anna for short. I'm at Elena Pharmaceuticals. I'm a nephrologist and a pediatric nephrologist by training. Have been in industry for about 10 years now. Yikes. Elena is developing a compound. It's one of the oxalate degrading enzymes that Dawn alluded to. Elena has participated with the OHF from the very get-go. I have a background in clinical research and such, and have experience with database-based research. And so immediately when the OHF first convened, even prior to the Kidney Health Initiative, I was volunteered and I gladly went along and participated. I think what's important for industry, and it's been very evident from my participation in the OHF initiative, is sharing. I mean, Elena has had multiple conversations with the FDA over the years, and so we have, had interactions, and we've shared what we can. Obviously, some information is confidential at these meetings, and we also have sponsored some of the clinical research databases that will be now part of what the OHF initiative, KHI initiative, will be. And in another world, in another disease area, we may not have been so willing to share, but we recognize that there isn't a lot going on out there as far as clinical trials in hyperoxaluria. None, zero to speak of, that are large enough or published enough to provide the very nice data that Patrick, another work group I had the privilege to serve on, we don't have that with hyperoxaluria. So we have to create it. And I think in industry, I've found it extremely helpful to be part of these initiatives. I hope that I've contributed from my own background and scientific knowledge. My company, which is headed by, our CEO is a scientist, and Lou Brenner was also here. He is the COO, but has been very open to share what we have sponsored, and we will continue to do so. And I think that's for the industry. Those of us in industry, we have to be willing to share what we've sponsored.
I appreciate that. And Anna didn't say that she actually served on the IgA nephropathy project before we started the hyperoxaluria one. So this is an opportunity for those of you who are in the room who see something coming down the pipe. There are opportunities for you to serve on these project teams and get an understanding of how they work before it's relevant to you. And Anna brought up a point around data, which is really important in terms of how we think about creating an infrastructure to share the data. So maybe this is a question a little bit to both Dawn and then Patrick as well, around how do we kind of think about collating these data or utilizing resources. There's probably more data out there that would allow us to provide the evidence that's necessary for some of these. Any thoughts that you might have around the value of the data and where we can bring it?
I'll try to start to answer, and others will add, I'm sure. I think that's a real challenge, the issue that Melissa just raised. And the obvious, the easy data is the published data. And that, you know, sometimes in a rare area like hyperoxaluria, it takes a bit of digging and looking and searching, but you can find it. That's the easier data to deal with. The more difficult is databases that are developed and held by individuals and not published yet. And there, I think the key is to get everybody on the same page working to the same goal. And once there's that investment in the goal, people are then, in my experience, usually much more willing to say, yes, count me in. I'll contribute what I can, and you contribute what you can, and we'll make something better out of this together.
Non-traditional, since I'm sitting on the panel, but I'm going to ask a question. So, you know, at the center of what we really want to do is to make sure that we're not just focusing on clinical things that we can measure in our lab, hospital lab. Are there best practices, best examples that we can use to model where patient-reported outcomes have been used for regulatory change?
Great question. And my mic wasn't on. Now it's on. I think that that's a great point. So part of what the discussions have focused on in the renal space have been things that we measure in the blood or urine that patients don't necessarily perceive. But what we're hoping and what we expect if we use it as a surrogate endpoint is that some treatment effect on that marker in the blood or urine will reliably translate into a treatment effect on outcomes that patients can perceive, how they feel, how they function, and ideally how they survive. But another important way, an important avenue for getting drugs approved is by showing impacts on the important symptoms of a disease and how the disease affects the patient. And certainly for a fair number of renal diseases, it's been hard to do that, and that's because I think, at least if you think about CKD, which is not one disease, but obviously many diseases, but in general, we think of it as a disease that is not highly symptomatic until patients get to the late stage of disease, and then even there, a lot of the symptoms are not specific. I think, however, that in some disease spaces, for example in FSGS, really a critical aspect of the disease is in fact the symptoms of the disease, of the nephrotic syndrome in the children. I remember hearing a very powerful testimony by a woman who's speaking at a NEPHCURE meeting describing how her children had I think a size 8 clothes that he wore sometimes and then had to bump up to like a size 14. And you could just imagine from all the edema, from all the swelling. And I think this gets to the issue in those diseases. I really do think we need to develop better instruments that are sensitive to the treatment effects on these symptoms. And I know that there's been some important work done in that space already, and very much hope we'll see more work done. And I'll stop because I know we're running out of time, Larry.
Right, I'll take one last question, and then we'll go to the next panel,
Sure.
because we're all between you guys and lunch.
This is just a follow-on to what Melissa said about value from your key membership. So she's talking specifically to this work group. So we did a survey last year, and we got some feedback. So thank you for those who responded to it. We're going to do it again. We want to make sure that you're getting value from your key membership. So just a reminder that we'll be sending that out later on. So.
Thank you. And because we have Laura up here and we haven't had a chance to hear from her, we can pass the mic down. Laura, you actually come to your study with a different perspective than Keisha. So if you'd like to talk about how you're going to view this in any different way, that would be kind of valuable for everybody to hear, and that'll be our last comment.
Okay, yeah, I had two thoughts. So One of the things I love most about FSGS and taking care of patients with FSGS is how heterogeneous it is. Not, one person is not like any other. And I think that that's a challenge, and it's going to be one of the things we really have to tackle. And I think FSGS is a disease that spans the life course, so I'm worried about surrogates that may be appropriate, like growth in kids and fertility in women of childbearing age and fractures in elderly. They may vary by the life course. So I'm excited to work on that particular problem with this project. The other thing I'm interested in that I was going to try to pull the audience a little bit is how to make sure that when we get the patient perspective, we're truly getting a broad perspective. Because FSGS affects such people across the life spectrum and many racial and ethnic groups, I think you get a diverse opinion about what matters most to the patient. And so I am not sure we have an infrastructure to do that broadly, something KHI could probably help us with. I know we have our advocacy groups, and maybe Paul Conway or Richard Knight have thoughts about how to do this, but I really worry that if we have 2 patients on our work group, that's not enough. And how do we get that really broad perspective so we don't go down a rabbit hole that's relevant for a small subset?
Yeah, one of the things you're worried about is if you have 2 patients, then you have just 2 patients and you don't have broader opinion. That's a great project for Key. Let's thank the whole panel, please.